Okay, so good morning. Well, good afternoon. Depends on the time out. My name is Dr. Nuñez. I'll be presenting Guillain-Barré syndrome. So, okay, first the content. We'll be talking about the introduction, epidemiology, clinical manifestations, etiology, pathophysiology, diagnosis, subtypes, treatment, and prognosis. So to start, we have to know what is Guillain-Barré. Guillain-Barré syndrome is an acute onset immune-mediated disorder of the peripheral nervous system. It's a disease that rapidly damages peripheral nerves. It may hinder movements, sensations of organ functions, depending on which nerves are involved. It was actually named after a French neurologist, Georges Guillain and Jean-Alexandre Barre, first described in 1916. So the epidemiology, since poliomyelitis has nearly been eliminated, the Guillain-Barré syndrome is currently the most frequent cause of acute flaccid paralysis worldwide, and constitutes one of the most emergency in neurology. While all of the age groups are affected, the incidence is increased approximately 20% with every 10-year increase in age beyond the first decade of life. In addition, the incidence is slightly greater in males than in females, and it's a very rare disease. It only occurs about approximately 1 to 2 cases per 100,000 people worldwide each year. The most common cause of sudden onset flaccid paralysis in developed countries. So what are the clinical manifestations? Well, it actually damages the myelin, as you can see, and the peripheral axons in Guillain-Barré syndrome. It is usually manifested in hands and also in feet at first. Patient usually presents a few days after onset of symptoms. A history of upper respiratory infection symptoms or diarrhea 3 days to 6 weeks before the onset is not uncommon. It's actually very common. The first symptom of the Guillain-Barré syndrome are numbness, paresthesia, weakness, pain in the limbs, or some combination of the symptoms. So you may feel like the paresthesia, which is kind of like a tingling and numbness. As the syndrome progresses, dominant features appear, such as the weakness, which progresses over 12 hours to 28 days before a plateau. So it gets to reach on its maximum. It can be very mild, or it can go very hard, in which it can cause complete paralysis of all extremities and facial bulbar muscles. So it can actually get to so complicated that can get to respiratory as well. Studies from the United States and Europe reflect primarily patients with acute inflammatory demyelinating polyneuropathy, which is a type of Guillain-Barré syndrome, because we can see afterwards that it has a lot of variants. So this one is associated with the weakness that usually starts in the legs and in the hands, and it goes upwards. So it can go to the face, or the facial muscles, and 10% of the patients, which can cause facial nerve paralysis. Oculomotor weakness as well, decreased or absent reflexes in affected arms or legs are found in approximately 90% of the patients. And in all patients with the disease progression, it can cause that decrease of reflexes. Electrical signal must travel the farthest to reach arms and legs. So usually you can see the paresthesia that will go first appearing in the hands and going upward. It is actually symmetrically both sides of the body, so that it's something that you can use as a diagnosis differential. The pain due to the nerve root inflammatory typically is located in the back and extremity. It can also be located in your shoulders and thighs, and it can be presenting features, and it is reported during the acute phase by 2/3 of patients with all forms of Guillain syndrome, and it will become quite severe with slight movements. Other malfunctions that you can present is the possible respiratory failure, that it can be led by the muscle weakness. So that happens to 10 to 30% of the people, and that can cause to ventilatory support. Though a very small percentage can experience respiratory failure leading to finally to death. Also, there can have also autonomic neurological system dysfunction, also called dysautonomia, that it also occurs in approximately 70% of the patients, in which the patients will have diarrhea, constipation, hyponatremia, can have also cardiac arrhythmias, can have bradycardia, can have tachycardia as well. And also you can have flushing of the face, orthostatic hypotension. The syndrome is actually inappropriate, can have a syndrome of inappropriate antidiuretic hormone secretion, which may due to autonomic involvement. And it's another complication of Guillain-Barré syndrome. It can lead to some of other features, but they're kind of rare, such as papilledema, facial myokemia, hearing loss, meningeal signs, vocal cord paralysis. The rate of the disease progression varies among the individuals. So you may see that it can progress during days or hours or even weeks. The max weakness occurs 2 or 3 weeks after the onset symptoms. By the 4th week after the initial symptom, 90% of patients have reached the end of the disease, but it can have some sequels. The disease progresses for more than 8 weeks to consistent with the diagnosis of chronic inflammatory demyelinating polyradicular neuropathy. So what are some of the etiology? You already hear some of them, which are the respiratory, the gastrointestinal, which are the most common. The gastrointestinal infection, you can see that it's usually caused by Campylobacter jejuni, which can cause gastroenteritis. It's actually an infection that precedes the Guillain-Barré syndrome, and it is the most common cause of gastroenteritis, resulting from food poisoning, and it's transmitted ingesting poorly cooked meat, poultry, or unpasteurized milk, and contaminated drinking water. Also, it can be caused by respiratory infections, which some of the most common causes are cytomegalovirus, Epstein-Barr virus, and mycoplasma pneumoniae, which it is characterized by sore throat 3 to 6 weeks prior to the set of Guillain-Barré syndrome, like the tingling and the weakness as well. A very small percentage can be caused by surgeries. It can be caused also by some immunizations, traumas, or even bone marrow transplantation. So you can see that it's very, very rare in vaccinations like the flu, influenza, or even pneumonia, but it's a very small amount. And it can be actually can be caused by influenza. So it's preferably you vaccinate. Also, it has been shown that HIV can also occur, has an association with a human deficiency infection, and it's because they're immunocompromised. Also, there has been association with COVID-19. Several cases of Guillain-Barre syndrome concur with coronavirus disease in 2019 have been reported through a direct causal relationship and has not been established how it's correlated. There is an association with also Zika virus with Guillain-Barre syndrome, but it has not been established how it has that correlation. Okay, so the pathophysiology, I will be explaining two main ones, which it's the acute inflammatory demyelinating polyneuropathy and the acute motor axonal neuropathy, as you can see in the presentation. So the first one, it's more like of a demyelinating form, which is the acute inflammatory demyelinating polyneuropathy. You can see that it's actually an immune reaction directed against the epitopes of the Schwann cells in the surface membrane or the myelin. And it can cause, it can be caused because the complement system is activated, and also the T cells are activated, which kind of activates the macrophage and damaging the myelin. You can also see the axonal type, which is this one, the second one. It is called the acute motor axonal neuropathy, and its immune reaction is against the epitopes containing the axonal membrane. So it is caused, it causes an acute axonal form of Guillain-Barre syndrome. And it is actually more severe and can lead to full axonal degeneration because there's another part that's called the acute motor and sensory axonal neuropathy, which is similar to the one of the acute motor axonal neuropathy, but it's kind of severe, more severe, but it has the same kind of pathophysiology. The damage is mediated by the complement, and this one is mediated by IgG antibodies and complement against the axonema. So both can result to the injury in peripheral neurons. So you can see that, as I'd explained, in the acute axonal neuropathy, its possible cause can be by Campylobacter jejuni, which as also some certain viruses like cytomegalovirus and also Epstein virus contain antigens with similar structures, as you can see, which kind of have similar structures as the gangliosides of the neurons, such as the GM1 and GD1. So this, it's actually called molecular mimicry, which is kind of like, because it has the same kind of structure, the body attacks, trying to attack the Campylobacter jejuni, it starts attacking the peripheral neurons, specifically those types of gangliosides, because they have the same structure. So you can see that it has a component of the oculomotor nerve myelin, which is associated with the Miller-Fisher syndrome, which is another variant of Guillain-Barre syndrome. And it doesn't produce, like, it produces anti-ganglioside antibodies. Another way is the one of the acute inflammatory demyelinating polyneuropathy, in which that one activates more the macrophages. So as you can see, it is more like has more like a hormonal as well. And this one is in the early stages can attack the nodes of Ranvier. So both the cellular and the humoral immune response participate in the process and invasion of the T cells, which are followed by the macrophages. So what are some of the diagnoses? There's actually a diagnostic criteria. There's some that must be shown. It is not in every type because there are some variants that are kind of variations. but the one that it's usually the most common, it can have progressive weakness on the legs and arms. So it is actually symmetrical, and it could go upward, as I had explained before. And then it also has areflexia or decreased reflexes in weak limbs. So those two must be to have like the criteria. But as I told you before, it's not in all of the variations, only in the most common. And then it can also have progression of symptoms over days to 4 weeks. It can have relative symmetry, mild sensory syndromes or signs, and cranial nerve involvement. There's also some laboratory that you can use. You can use the cerebral spinal fluid analysis with a lumbar puncture, in which higher levels of proteins and normal white blood cells, or less than 10 millimeters, can actually show you a diagnosis, which it can be used to as a differential, because in some of other pathologies you can see those two increase, but in this one only the proteins are increased and the white blood cells will be less than or in a normal stage actually. So this is called this albuminous dissociation, which actually is presented in 50 to 66% of the patients, and which, as I have told you before, it will have the elevated proteins, and which may be due to an increased permeability of the blood nerve barrier at the level of the proximal nerve root. So a normal CSF protein is found on 1/3 to 1/2 of the patient, but it's usually higher the level. You can also find pliocytosis common in patients with Guillain-Barre syndrome, and it's concurrent in human immunodeficiency virus, so in HIV. So that is common in those. You can also use neurophysiology studies such as the nerve conduction studies and the electromyography. It is not required to have the diagnosis, but it will help you differentiate with other types of diseases. So in addition, you can use, for example, the electrodiagnostic studies in classifying the main variants of the Guillain-Barre syndrome, and the demyelinating, the acute inflammatory demyelinating polyneuropathy, or the axonal as well. So for example, in the demyelinating form, you will see features like demyelinating, including decreased motor nerve conduction velocity, prolonged distant motor latency, and increased F wave latency, which also has conduction blocks and temporal dispersion. Now, in the axonal form, you can see decreased distal motor and sensory amplitude, transient motor nerve conduction blocks, and conduction failure can be prevented. The nerve conduction studies, it usually actually electrodes on the skin on different locations. So in this one, it kind of stimulates the electrodes, and the other electrodes pick up the electrical activity in the nerve. So it calculates the distance between the electrode and the onset and the one that transmits the impulse between the electrodes. So usually the Guillain-Barre syndrome will have a slower nerve conduction. And the EMG test the the muscles in response to a nerve stimulation of the muscle. So it has decreased a recruitment of the muscle, even in rapidly timing motor units. You can use also antibodies in a clinical practice. The commercial available testing for serum of IgG, antibodies, and GQ one is useful for diagnosis of Miller-Fisher syndrome. The MRI may reveal thickening and enhancement of the intrathecal spinal nerve root and the cauda equina. So that also can help you diagnose. The anterior spinal nerve root only may be involved, or both anterior and posterior spinal nerve root only in some cases, such as except on the Miller-Fisher syndrome. Well, as you have heard before, I've been telling some of the variations. For example, the acute motor sensory and axonal neuropathy is similar to the one mentioned before of the acute motor axonal neuropathy, with the difference that in this one, it's more severe. It actually attacks the GM1 and GD1, and it usually affects adults in this situation. The one of the Miller-Fisher syndrome, it causes weakness in eye muscles, as I had explained before, because of the, it attacks the neurons in there, and the ataxia or reflexia, which usually doesn't cause weakness in the lip, which is one of the kind of variations that is different from the usual syndrome, Guillain-Barre syndrome. It is also usually common in adults, and you also have the pharyngeal cervical brachial variant, which causes weakness in facial and cervical and throat muscles with no lower limb effects. So the treatment, you use plasmapheresis, which is a plasma exchange. It removes antibiotics and other immune mediators from the blood and contributes to the destruction of neurons. You also use immunoglobulins, which from donors, which clears all the damaging immune substance from circulation. You don't use corticosteroids because it has been shown that it can actually worsen the situation. Mechanical ventilators are usually used when it has a respiratory failure, and they can even go to ICU because of the risk of pneumonia and other atelectasia, which are greater in patients that are paralyzed. You can also use antibiotic in those cases when you have kind of cases of pneumonia. Manually move limbs to keep blood flowing and decrease the risk of blood clot formation, because those patients generally are doesn't have any movement, so they can provoke vein thrombosis. So you use anticoagulant therapies because of the immobilized patients. Physical and occupational therapy may be used once you have like more improvement, and that will help patients recuperate the movement. Psychological counseling may be also used because usually these patients suffer some difficulty with the sudden paralysis. The prognosis, actually, it's a common misconception that the Guillain-Barre syndrome has a good prognosis. Usually, most of them have a full recovery in 6 to 12 months, but 20% of the patient can remain with severely disabled, and approximately 5 die despite of the immunotherapy. So 2 to 5% of the Guillain-Barre syndrome patients die because of the respiratory paralysis or cardiac arrest, but most of them do recover in 6 to 12 months. Though 30% of the patients can have residual weakness after 3 years, and 3% of the patients remain with the weakness and tingling many years later. So that will be all. This is some of the bibliography I used for this presentation. I don't know if you have questions that I may answer.
Thank you.